Bismillahirrahmanirrahim. First, I would like to extend my gratitude to the scientific committee for giving me this chance to present our experience on decompressive craniectomy for middle cerebral artery infarction. We have no disclosures. So, large hemispheric strokes are known for its effect on morbidity and mortality. Early deaths usually occur from a massive edema causing herniation. Other vascular territory might be involved as anterior or posterior cerebral arteries, in addition to the middle cerebral artery as the edema propagates. Decompressive hemicraniectomy has been shown to significantly show great promises for these cases, especially if addressed as soon as the diagnosis is made. Our main objective was to assess our preliminary experience with decompressive surgery with middle cerebral artery stroke in two tertiary care centers in Western region in Saudi Arabia. We retrospectively reviewed the operative records for a period of 5 years. We had the experience from two tertiary care centers, King Faisal Specialist Hospital and Research Center and King Abdulaziz University in Jeddah. We evaluated the initial NIH score, the pre- and post-operative glaucoma score. The inclusion criteria were mainly for all patients who underwent decompressive hemicraniectomy for a middle cerebral artery stroke. We evaluated all the medical treatment that has been received for all the patients. We excluded cases who underwent decompressive hemicraniectomy for trauma or those who underwent the surgery for a pure intracerebral hemorrhage. We assessed mortality at 3 months and then again at 1 year. We followed the patient for a total of 1 year following the functional outcome, evaluating it through Barthel Index and modified Rankin scale. And all values were expressed as the mean standard deviation. For the sake of time, I'm presenting only an example of the cases. We had this patient transferred to us 24 hours after he developed his symptoms. This is the initial CT scan showing a significant hypodensity in the left side of the hemisphere. Here, the MR angiography showing complete absence of the middle cerebral artery, and the MR perfusion and diffusion had confirmed an acute ischemic stroke in the middle cerebral artery territory. This patient had received the maximum medical therapy over a period of 12 hours, and then he continued to deteriorate despite that. So he was rushed for surgery, and he underwent this large decompression surgery involving the frontal, parietal, lower down to the temporal, and then some part of the occipital as well. This is how the brain looked like after opening the dura, showing a significant swelling. And then closure was done using duroplasty. This is his CT scan post-operatively, showing a significant improvement in the midline shift. And some areas were improvement in the basal cistern as well. So this table summarizes our results. We had a total of 6 patients included. Male predominance was noted. An age of 41, a mean age of 41.6 years. As you can see here, the post-operative GCS was actually a mean post-operative GCS was actually worse than the pre-operative GCS, and I will tackle this in the discussion. The mean time from symptoms onset to surgery was about 48.8 hours. We had equal dominant and non-dominant hemispheres being operated upon. We had 2 patients who developed complications. One of them developed significant post-operative rebound edema, and the other patient developed post-decompression hemorrhagic transformation. Mortality encountered in 4 out of 6 patients. 3 out of these patients died within the first week after surgery. So this topic has been extensively studied in the literature. It receives attention recently specifically for middle cerebral artery infarction cases. In our report, we report a mortality rate of up to 66%. This is by far the highest rate of mortality that has been reported in the literature. We can actually explain that by the fact that there was a great variation in the timing and the threshold of the surgeon for taking the patient to surgery. One case had a delay of management reaching up to 6 days after the initial symptoms. In one series by Fondino et al., earlier intervention within the 24 hours before the occurrence of herniation symptoms had reduced mortality down to 16%. In our study, the overall complication rate was actually less than the overall reported number in literature from a recent systematic review. In one study, the development of hemorrhagic transformation after surgery was associated with worse patient outcome, and this can explain why maybe some of the patients had a worse GCS than the preoperative score. We found that there was no significant change in the patient functional outcome with regards to Bartter index or the modified Rankin scale. They were both actually lower than the numbers reported in the literature, and most of the patients, actually about 2/3, were within the range of modified Rankin scale more than disability scale more than 4. So as we conclude, we advise that early surgery should be considered for these cases within the first 24 hours and actually just before the irreversible clinical signs of herniation occurs. The high post-operative mortality and the relatively poor functional outcome reported in our series actually deserves careful further analysis to why it's actually happening. The variation in the surgeon's knowledge and attitude towards decompressive surgery could be an important factor and should be studied thoroughly. Thank you very much.